Okay, hi guys. We're going to talk about the child with an infectious disease. This is actually a short kind of PowerPoint. As we start this, I'm going to talk about first the pediatric differences, like we usually always do. So, for the first part, infants and young children are very susceptible hosts, and they are for many reasons. One being that their immune system is not mature at birth yet, and protection by immunization is complete. So they have immunodeficiency. They also have very poor health habits, right? Poor hygiene of kids definitely increases their rate of transmission. The most common modes of transmission are fecal oral and the respiratory route for kids. Maternal antibodies, this is actually a mistake, so if you will cross out the 20 days, I'm about to tell you the real one. Okay, so maternal antibodies, they protect the baby for actually about 1 to 2 months. Actually cross that, sorry. They actually protect the baby, can be up to 1 to 2 years, but they start decreasing around 1 to 2 months. And every baby, in terms of how many antibodies they have, is different. So it's really highly dependent on how many antibodies are in the maternal plasma. But roughly, you can bet that around 1 to 2 months that the antibodies in the infant's bloodstream, they are starting to decrease. And most are actually gone by 6 to 9 months, but for some kids it can last longer. Breastfed infants definitely receive more maternal antibodies for longer, as you guys already know. That's why we definitely encourage breastfeeding. The types of immunity are passive and active types of immunity. Passive being one great example, since we were just talking about it, is the mom, and the maternal antibodies that can be passively given to your fetus. It is important to note that passive immunity does not provide lasting immunity, right? So it will not be forever. But some of the things that we provide and administer are the tetanus immunoglobulin, which is why we need to get a booster every 10 years, and intravenous immunoglobulin, or IVIG. We do give this in some instances to provide our patients with immediate protection, but again, it does not last forever. Now, active immunity does. It's the natural immunity. So you can either get this from actually having had a disease yourself, or through something like a vaccination, where we introduce an antigen into the body that is a killed or a weaker version, and it allows the person to develop antibodies against that antigen if any future invasion happened. So one of the things we're going to talk about is congenital rubella. Congenital rubella happens when the rubella virus crosses the placenta and infects the fetus. So basically, it's a maternal infection. If the mom gets infected with rubella during pregnancy, there are serious consequences to the fetus. Rubella can cause fetal death or congenital malformations. One of the common clinical manifestations actually in pregnancy would be intrauterine growth retardation. These infants may weigh less than 2,500 grams. And if they survive, many of these neonates and infants have failure to thrive as well. Deafness is also a very common complication of this disease. Infants who have congenital rubella are assumed contagious until they're 1 year of age, or they have a nasopharyngeal or urine culture that has repeatedly been negative. Now, the primary prevention of rubella is a vaccination, which comes in the form of an MMR. So this is a live vaccine. It contains a microorganism in a live but attenuated or weakened form. It is important to note that The administration of this vaccine is contraindicated in people who have a history of anaphylactic reaction to neomycin, eggs, or gelatin. You add gelatin up there. Also for any immunodeficient patients, any patients with a history of ITP, like we talked about in the hematology PowerPoint. It is contraindicated in pregnant women. Side effects of this vaccine are maybe potentially a light transient rash for 2 weeks after. We do administer, recommendations by CDC is to administer this vaccine from age 12 to 15 months for your first dose, and then second dose between 4 and 6 years of age. It is important to note with all live vaccines like this one, we do need to make sure that we are postponing the administration of this vaccine for any people who have been on high-dose steroid therapy, meaning they have been on a steroid therapy for 14 days or more. So varicella in the immunocompromised child, what's important here is that an immunocompromised child who gets varicella may have hemorrhagic lesions, and varicella pneumonia is a common complication. Some children develop an acute form of varicella, also with disseminated intravascular coagulation, which can be fatal, and secondary bacterial infections can occur. As I said before, healthy kids who have had steroids before infection may develop serious complications because they're immunocompromised as well. The contact precautions, or the isolations, precautions for a child with varicella are airborne and contact precautions. So be sure to isolate your patients, and also if a child gets varicella at home, we do need to make sure that we are informing the parents that they do need to stay isolated as well. They also need to make sure that they let the school or daycare facility know that they have chickenpox or varicella vaccine. So immunity pertussis. Infants are highly susceptible to pertussis because they don't receive maternal immunity for this. So you guys remember pertussis, the whooping cough? It's very highly contagious, and it's associated with very high infant mortality. It's got the 3 stages of cough too. It's really, really horrible. If you guys want to ever hear it, there is, if you YouTube it, you can actually hear the type of whooping cough and what it sounds like. But contraindications to this vaccine are any encephalopathy within 1 week of a previous dose, any seizure history that happened within the last 3 days of a previous dose, any neuro signs and symptoms after vaccine, or any systemic allergic reactions to vaccines. So think of your neuro signs and symptoms in general, as we discussed what the neuro assessment would be last time, but things such as inconsolable crying, fussiness, pale or limp episode. The fever portion of this, you want to see if it's a fever over 105 degrees Fahrenheit. So all of these would be a contraindication if happening after a previous dose. There are a total of 5 doses that CDC recommends that we give in the DTaP version. They should be given at 2, 4, 6, and between 15 and 18 months, another one at 4 to 6 years, and then the CD added another one between 11 and 12 years. Vaccine administration guidelines. For this part, it's just really important to note things that are not contraindications. So for an immunization, so mild acute illness with low-grade fever, any mild diarrhea, an otherwise healthy child. And if there was a little reaction to a previous immunization of soreness, redness, and swelling at site, that is normal. That's considered a normal side effect of a vaccine. Additionally, if some irritability and fever under 102 degrees Fahrenheit is normal, is considered a normal finding. So acetaminophen is recommended. Well, it's not necessarily recommended, but I mean, it's recommended that you can give your child it every 4 to 6 hours as you need it for if they're uncomfortable. For any leg soreness or treatment, you could try a warm washcloth and sometimes bicycling the legs with every diaper change can help as well. Call healthcare. We do need to let our parents know to call healthcare workers if there's any seizures, high fever, or high-pitched crying. We also do need to make sure that we are encouraging and following the recommended immunization schedule. The most up-to-date and frequent one is found on the CDC website, so that is where I recommend that you go to always see an updated version. It is updated yearly to kind of make sure that we are keeping up with the latest terms, but this is one right here. I really encourage you to look through these extra resources. Education is powerful in terms of what we can learn and provide our families. If you have any questions with the vaccine schedules or what to give or what we can't give, and in terms of allergies or immunocompromised kids, in terms also of a delayed or slowed immunization schedule for special populations, you can look on the CDC. Also, you want to look at how vaccines stack up against other common causes of injury in the history of vaccines. That's a really interesting one. And the animation about herd immunity. Really quick, we're going to cover fever. So the definition, really, like I said before, for fever is a temperature of 100.4. That's kind of when we start getting excited here. Pathophysiologically, what happens with a fever is really what is that the hypothalamus is our kind of our thermostat for our internal body temperature. When a microorganism invades the body, some endogenous pyrogens are released into the bloodstream. So what happens is the body produces prostaglandin E, which inevitably raises our body temperature set point. So when we raise our body temperature set point, our hypothalamus stimulates this cold response, and shivering and shaking chills is where we can get an increase in metabolic action and heat production. So when this happens, the hypothalamus then maintains the temperature at a new set point. You'll see an increased metabolic rate, an increased respiratory rate, an increased heart rate. The skin may flush and cause vasodilation. Or you can also see sometimes vasoconstriction and decreased peripheral perfusion by blood shunting to the core of the body. We do need to remember not to treat fevers with aspirin. You guys should remember this from neuro. And frequently assess your vital signs. really quick. It's important to remember a fever is not a disease. It's the body's response to an infection. So if the child has a fever and doesn't really look super sick, it's sometimes better to let the child's body's natural defenses fight off the virus or the bacteria causing the fever, but follow guidelines when to contact the child's healthcare provider. So we do need to make sure that we're telling them they have to call the doctor if the infant's under 2 months and has a fever over 100.4. And if the child has a fever over 104.2 and any of these symptoms I'm going to say, they also need to call the doctor. So child's crying inconsolably, the child's difficult to awaken, the child's neck is stiff, there are purple spots present on the skin, any breathing is difficult and no better after the noise is cleared, the child is drooling, saliva is unable to swallow anything, the child has any convulsion or seizure or acts or looks very sick, definitely want to call the doctor immediately. But otherwise, traditional care for a fever would be to continue to take the temperature every 4 to 6 hours, use Tylenol and Motrin as needed, definitely no aspirin, and remove all but a light layer of the child's clothing and monitor for the child's behavior and response to fever medication. All right. That's it with fever. Now moving on to diagnostic tests. I'm not going to review this because you guys should know this, but you guys should go back through that and look at that. And the last disease we're going to talk about is impetigo, and it is very super contagious, and it's a superficial bacteria skin infection. It's actually the most common one. The way that most common ways for a portal, like into your body, for the infectious agent to get in for this is through minor skin injuries, insect bites, or dermatitis. The most common organisms that are related to this infection are Staphylococcus aureus and group A beta hemolytic streptococcus. This rash is usually seen on the face, scalp, buttocks, and extremities. It does have a 7 to 10 day incubation period and contagious. It's contagious until lesions are healed. And usually these lesions are resolved in about 12 to 14 days with treatment. Here are some pictures, because what happens usually is they begin as a papule and then they develop into vesicles that rupture, leaving a honey-colored crust. And you can see that here on the right here. Lesions are very pruritic and they do bleed easily. They actually more commonly form in moist skin fold areas, so you'll want to look in those areas as well. Treatment for this is to soak with warm water and remove with antibacterial soap in about 3 times a day. Most commonly, we give topical antibiotics and put to these lesions for 7 to 10 days. Leave the lesions open to air. If severe, may need oral antibiotics, and if really severe, then you may need IV antibiotics. So parent education is important, and one of the things being is that if you're a patient, you have to tell family, if the patient does not improve in 24 hours of the treatment that was given, they need to come back. They need to call their doctor because they may need to come in and get skin cultures, wound cultures. Additionally, we need to teach parents to wear gloves when they're caring for the lesions. They need to keep the child's fingernails short and washed. Child should sleep and bathe alone with antibacterial soap, and no sharing of items. Patient needs to have their specific towel, combs, eating utensils with no sharing. Very good hand washing is essential in the whole house. Additionally, when doing laundry, let parents know that they should be doing this patient's laundry alone in high heat and antibacterial soap. Transmission of pathogens, I'm not going to read this to you. You guys can read this. This is a review for you, hopefully. Just a reminder of all the different modes of transmission. And this is for you as well as a reference for IM injections. And that we do most commonly give them in the vastus lateralis. And that is it.